diagnostic modalities, as mentioned, we do the endoscopy together with the endoscopic ultrasound and fine needle aspiration biopsy.
Okay, so you did the endoscopy first for this patient. So you explain why endoscopy first.
Yes, doc.
Okay, versus CT scan first.
Mm-mm.
Yeah, why you opt to do the ultrasound guided FNA outright? Okay. Normally, these patients, you would opt to get a CT scan first. Okay,
Okay,
so okay, before you do the FNA, naman na indication which patients with GIST you would need a biopsy. Because if you put there, if you read on GIST, it's biopsy is not needed.
Mm-mm.
Okay, it's only needed if you want to do pre-op therapy. So
Mm-mm.
if you don't plan to do neoadjuvant therapy, then that means you don't need to do the biopsy. So which patients will need neoadjuvant therapy?
Yes,
So kana
doc.
siya nga findings, the patients that will need neoadjuvant therapy, most of the time those are CT scan findings. It's in the CT scan.
Mm-mm.
So the tumor is big,
The tumor
patient
is big, yes.
structure, etc.
Usually the size. Yes, doc.
Oh, so those things you can find in the CT scan.
Mm-mm.
So that means if wala kay CT scan, you cannot decide whether you need preoperative therapy or not.
Or not. Yes, doc.
So in the proper workup, you can even do the endoscopy first without the FNA. Just do the
mm-mm.
endoscopy, then confirm that this is probably GIST based on endoscopy. Then get
Okay.
the CT scan.
Okay. Sige, doc.
Then
Noted.
aside from the CT scan of the abdomen, what else will you get? Okay. Then after that, you reviewed your CT scan of the abdomen and found out na
Dako ang mass.
so you will not do the surgery first. You want to do pre-op therapy. Then you go back and send the patient for endoscopic FNA.
Mm-mm.
So dili na siya na after endoscopy automatic na FNA mo.
Mm,
That's not
okay,
the
sige, doc. So okay. So what to siya? So originally we planned to do the endoscopy together with the biopsy, but okay, we will edit that and then do contrast CT first before doing the biopsy.
Okay, so you already have the finding, huh? You explained the CT.
Yes, doc, we will. The results are here. It's presented. Then for the final diagnosis, it's gastrointestinal stromal tumor stage 3B.
So what else do you need aside from the CT scan of the abdomen?
We also need the biopsy results, doc.
What else? Asa mo na raw? Balik atong slide.
Okay.
Oh, saan sa may kulang?
The MRI.
Dili. Isa pa man. For all workups at GIS, what do you need? How do you stage? What if metastatic?
The PET scan, doc.
What else? If not, wala scan.
Okay.
So, di ba, you need your chest imaging. So, in this patient,
Also the X-ray.
oh, so X-ray na siya.
Okay, doc.
Okay, so negative naman yung X-ray, but the ideal is just a CT, chest CT.
Mm-mm.
Okay, so if the patient has one, ideally na chest CT, get.
Okay, doc. But we also will be ordering a chest X-ray put, doc, prior to the endoscopy, so we can just note that we actually requested for the X-ray.
No, but the ideal is always going to be the CT.
Okay, doc.
Chest CT. Okay. Sige, continue.
Okay, so we have the results of the contrast CT scan here. Then it results and then final diagnosis. And then for the treatment and management, so here first we begin again with the imaging and biopsy, then we what do you call that term? We assess the risks of
Okay,
the then the adjuvant therapy and so on. And then so here is the neoadjuvant therapy that we would be doing using imatinib. Then this is the FDA approved call this dosage of the drug. Then imaging to assess the response to the preoperative treatment. So PET scan
so
um
why did they get the PET scan?
to assess for metastasis, doc.
Is that, but they
And the size, sorry, doc.
look at that time. Look at that time.
At 2 weeks after the interval, doc, to check
So
the size of the tumor
really,
if it
is that the size? So why PET scan? Because if you want the size, you'll get a CT.
okay, doc.
Doc, from differentiating from active tumor from necrotic or inactive scar tissue,
Again,
PET scan. Differentiating active tumor from necrotic or inactive tissue to differentiate, we get PET scan, and also to assess the response to the therapy with imatinib.
no, but yeah, but why do you have to get 2 weeks after? But based on your readings, it naman to dito. Based on your readings, what's the purpose of getting a PET scan 2 weeks after? So you read that na lang in case you are asked during the actual presentation, ha? So,
Is it that we need rapid readout of the activity?
come again?
Rapid readout of the activity. Because we closely monitor the patient.
Oh, but what are you monitoring in the PET scan? What are you looking for in the PET scan? That will tell you if you find this on the PET scan, then that means your therapy failed. And what will you do next? Okay, because remember, GIST has a very high risk of distant metastasis. No, it's very high risk for distant metastasis. That means if your treatment is not working, it means it will metastasize. You don't have the genetic or the molecular subtyping for this GIST. So you're not sure if this GIST is imatinib susceptible or not. Diba? Because we don't have the genetic subtyping for this one. We're not sure if this one is a c-KIT mutation or not. For this patient, we only have the CD117. So we're not really sure if this type of GIST is what subtype of GIST this is. Is this the imatinib susceptible? Is this the imatinib resistant? So that's the reason for your PET scan. If you want to do an early assessment on whether your therapy is working. So what in the PET scan should you look for? That will tell you, my therapy is working, I can continue giving my imatinib. I will not worry about metastasis. Okay?
Okay.
So it's there in your NCCN. I think you're already reading NCCN. So it's in the NCCN, the principles of imaging.
We'll review the guidelines na lang, doc.
Doc, is it the metabolic changes or metabolic activity of the tumor?
It has something to do with the metabolic activity because this is a PET scan. So PET scan is always metabolic activity. So it's not size or anything. Your tumor could be very large, but the metabolic activity of the tumor is small. On PET scan, it will appear as small. So, it does not correlate to the size.
Okay, doc, noted.
Okay, doc.
So what will you look for in the PET scan? And at the same time, this one, got to go back. Next slide. What will you look for on the CT scan also? Okay, so you already have that different. You already have that impression there. So you have to identify what are you going to look for in the CT scan that will tell you I can continue with my therapy, as well as go next slide. This one, okay? So what will you look for on the endoscopy? Because there's an endoscopic changes. Normally we don't do this anymore, but this patient, they did it, no? And I'm giving you the picture so that you can also see the endoscopic changes in the tumor. So all of this, what is the purpose of your PET scan and the CT scan while doing the treatment? Diba? It's all to monitor whether
To
your patient is
monitor.
responding or not. Because you don't want to keep giving the imatinib only to find out after how many weeks
It's not
that
working.
your imatinib has not, your patient has not responded and the mass is getting bigger and bigger. So what you're trying to look for are the changes in the CT scan, in the PET scan, and in the endoscopy that will tell you that your therapy is working. That will give you the reason to continue your therapy. So what if it does not work? So what's your option B? Okay. What is it does not work? What is your option C? So those are your management principles for GIST, and that is how you should present.
Okay, Doc. So after this, we proceed. So since it was noted that um the pre-op treatment was working, the chemotherapy, and that the size of the tumor has reduced over time, we could already recommend surgical resection.
So kanya when do you recommend surgical resection for your tumor?
Oh, yes, Doc.
So you read, when are you going to tell the patient na, okay, this is the best that we could give you. This is the smallest that this tumor is going to get, giving our imatinib. So we will do the surgery now.
Di ba ano, Doc, ask ako, Doc, di ba most likely, ano lang man, Doc, ang proper time naman niya, Doc, is like resectable on tumor at the same time, ang size niya is reduced na siya for resection. Na ba diya along the line, Doc?
Oh, but when man ka mag-repeat sa imong imaging? Kay, what if your tumor is already resectable? Okay, resectable na ang tumor, but what if your imatinib, that's the maximum response that your imatinib can give you? Because if you're trying to shrink the tumor, let's say for this patient, what if you want the tumor to become 2 cm, less than 2 cm? What if you wait for the tumor to become less than 2 cm? That might not happen in this patient. Okay, so there's a timeline na how long are you going to give your pre-op imatinib, and what is the maximum response that your patient will have before you decide to bring the patient to surgery. So not all of that time na you could achieve the ideal na resectability. Okay, what if the tumor, let's say in this patient, the tumor, what if it involves the spleen? Despite giving your imatinib, it shrunk a few centimeters, but it still involves the spleen. So what are you going to do? Are you going to give another drug, or are you going to continue with your imatinib? So those are your principles. Okay, when you offer the option for surgery, you have to consider when is the best time to do surgery on this patient. Is it really when the mass is small and resectable, or are there any other criteria that you need to look for that will tell you na this is the best that I can get from this patient with this treatment? And it's also there in your principles of neoadjuvant therapy in your NCCN. So naran dito, ha? So just read on that.
Copy, Doc.
Nalagibota dito na after giving imatinib, when are you supposed to do the scan? When are you supposed to do the PET scan? Okay, what factors you look for that will tell you na, okay, this patient is candidate for surgery. Okay, then before the surgical resection, what do you need to do to this patient first? Okay, so before you do, di ba, you said, you mentioned you completed na inyong initial management. No, so after that, what do you need to do before you offer surgery for this patient? In to simplify, ayaw mo pagditso sa surgery because this is a 60-year-old man, 60-year-old female.
Yes, no.
Yes, no.
So how do you make sure na by the time that you considered surgery, ang mass is still the same location, no, wala siya na metastasize, then how are you going to make sure na ang patient makaya niya ang procedure, di ba? So ina na siya. Then expound this for patients more than 2 cm or greater. So does that mean na all JST that is less than 2 cm can be managed medically only? Okay, so read on that. Nana siya gibutan dito sa NCCN. Okay, dili na siya tanan. Okay, so next. See you next slide.
Doc, excuse me.
Okay, go ahead.
Is it okay is it okay to perform laparoscopic surgery for this patient since the tumor is 5x5?
It depends on you because that's your management. But just read on. That's why I told you the updated. In CCN, they updated the guidelines. So before it was very limited, like tumors less than 5 cm, and it has to be located in the favorable location, like anterior gastric wall or in the fundus. That was before. Okay,
Okay.
now they change it. So just look at what's the changes in the current guidelines, and does your patient fit the criteria?
Okay, Doc. Thank you.
So after surgery, we proceed the post-operative follow-up.
What will you give post-op?
So here, Doc, before we will give the patient with the first line or your imatinib, we must first know what is the risk factor of our patient. Since after surgery, our patient had 5x5 or 5 cm, so we can consider that our patient is in the intermediate risk. So according to the new guidelines, Doc, you can give the patient imatinib for 400 milligrams one day, daily for at least 3 to 3 years. Then give the patient high.
You give that sa kuha na lang, the actual.
Sige, sige.
So just remember na the reason why you're giving that, why are you giving
Yes.
the imatinib, and can you not give the imatinib in this patient? So you have the kuan first, so you already have the histopath report for this patient, and you also have the staining report for this patient. So correlate that in your post-op management. And aside from your post-op management, next slide ko, no? Okay, next slide. So
Doc, for the
surveillance.
sorry, Doc, excuse me, Doc, for the previous slide, Doc, ba, katong
Go, ipakita ko na.
kaning recommendations, Doc, I've included the staining, Doc, for Ki67 gene and for the PCNA gene, Doc, because this will help man assess the patient, the proliferation or the mitotic division of the cell, then correlate it together with the NIH na chart. So is it okay, Doc? Then I've also included the markers, the biomarkers.
It's okay if you have this, let's say if you're in an ideal setting. But for this particular patient, you only have the staining for, I think, CD117 o katong S100.
Sige.
Do you
Ako lang
also correlate that?
okay, but ako lang i-include for like what is ideal truth for the patient.
Okay na siya. You can include that.
Sige, Doc. Then we will give the patient 800 milligrams daily if there is a resistance of the imatinib.
So how are
which
you
will
going
occur.
to know that there is resistance in imatinib for this patient?
I think, Doc, is it not kanang recommended, Doc, that we will give we will have gene mutation testing, Doc, so that we would be able to know what are the kanang asa susceptible ang patient sa drug and asa pud siya sensitive, since 50% of the case mong good kay kanang they will have resistance to imatinib. That's why we will have the second line unta, but it's for the neoadjuvant mong good. So
that's why for these patients you need genetic subtyping, but that's ideal. But for this patient we don't have that. So how are you going to know that there is resistance in the adjuvant?
Dili na mo there is failure, Doc, for the kanang patient.
How would you know that there is failure? So siya. Those are the things that you need to consider. Those are the possible questions, Manggod. So what will tell you na you need to increase it to 800? Because you wrote there increase 800 if milligram daily if resistance occurs. So what will tell you na siya resistance?
Doc, I have a question, Doc, ba? If mag-resistance baga po na ang kanang kuan, Doc, ang patient, Doc, if ever sa first treatment, Doc, kay wa sa nag-resistance, Doc, kay since gamay man iyang tumor, Doc, so
that's why before, even in the pre-op, that's why I told you na you need to have the criteria in which you can offer the surgery for the patient. Because when you start your imatinib, it might be responding very well. But the more you progress, the lesser the response might become. So that's why, settle na mo ba nga, this one is okay na niya for surgery. It may not be the best outcome, but since resistant naman ang patient sa imatinib, okay na ko ani. Ano na siya. So it's the same. The patient can develop resistance to imatinib. That's a problem with GIST.
Sige. Should I include yapon, Doc, ang katong mga treatments, Doc, for like katong mga second line, third line, fourth line here, Doc, or dili na lang, Doc?
No need na. You can put that in the discussion because this is the case man, your patient.
Okay, so no need. Thank you, Doc. Thank you, Doc.
Sige, next slide ka na. Okay, so for your surveillance. Okay, so be specific with your surveillance. How often should you do the CT scan?
It's here, Doc, na the patient will have completely resected GIST, so the patient should have a thorough history and physical exam for every 3 to 6 months. So if there is a less tumor with less than 2 centimeter, okay, there is the surveillance may be acceptable in less frequent kanang survey. Then abdominal or pelvic CT scan should be performed every 3 to 6 months for 3 to 5 years. Since for the 5 years span, okay, there is kind of 50% survival rate only for the patient. That's why we need to kanang have a kanang monitoring of the kanang CT scan of the patient.
Okay, next. So in yung case discussion. So case discussion, just focus more on the JST. Sige, next. Okay. So for staging, Okay, next. So also focus on your imatinib treatment ninyo. Why are you giving imatinib? Okay, what is the second line? Okay, and then why do you need surgery for JST? So kaya lang, that's all you need. You don't have to go in detail. So ayun na mo pag-discuss o katong mga histopath for the JST. You don't need that. What you want to do in the discussion is you want to defend your management manggod sa patient. So for your patient, like example, you did preoperative imatinib. So you discuss what's the gold standard, what's the principle behind preoperative neoadjuvant therapy. Then why do you need preoperative adjuvant therapy? Why not just remove everything? Okay, why not just remove the stomach, remove the entire stomach, remove the entire spleen, everything that the GIST will touch. Why not just remove that, just like in gastric cancer? Then you did surgery. Okay, so principles of surgery. What do you need to talk about in surgery? And then adjuvant imatinib. So those are the things that you need to focus on when you come to your discussion. So basically, inyo na lang gina-defend ba? Defend your actions as to why you did those in your case. Okay, so any other questions?
Doc, I would just like to clarify, Doc, earlier in the initial management, Doc, you said dili na mag-give og metoclopramide and then katong hyoscine, Doc. Can we give PPI instead, like omeprazole, Doc, and then ibuprofen for the pain management of the patient?
Actually, the patient is not in one discomfort, no? But you can give the PPI, but do not give the IBU. We don't want to give IBU for acute mga cases. Okay, so any NSAID, especially kung nag-bleed ang patient, because if you look at the pathophysiology of your NSAID, no, mag-cause maguna sila o katong vasoconstriction sa inyong renal artery, hypotensive mong patient, pati nakag-renal blood flow, natagan pa niyo mo, i-constrict pa niyo mo yung renal artery. So giving NSAID on a bleeding patient can exacerbate the renal failure. So ayaw. So that's why kani bisag PPI lang, actually PPI ra na inyong ihatag. And you can give it in BB if you want for the pain. But most of the time, the pain will be relieved by the PPI. Kay bleeding man na siya.
Thank you, Doc.
What na lang niya, actually fluid. Kay kung man na siya acute resuscitation ba, you don't actually plan to give the medications for a prolonged period of time. You just want the patient to feel comfortable during the initial resuscitation period. Okay, so what else? Okay, remember your HNBB can also cause hypotension in some patients. Dili na mo. Remember, your HNBB, the action of your HNBB is basically an ACTH inhibitor. So dili na ka makabasoconstrict sa imong HNBB. And if your patient starts to fail, mag-need ka og norepinephrine, which is a vasoconstrictor, yan naka HNBB, then your HNBB might not work. Or your norepinephrine might not work. So that's why we don't give HNBB outright. No, kana lang yun na siya stable kay nga patient na in pain. We can give that. But for this patient, even just a PPI should suffice.
Thank you, Doc.
Sige, what else?
Excuse me, Doc. For surgery, you said that we have to do what will we do before surgery. So do you mean pre-op preparation of the patient or something else?
Pre-op preparation of the patient and your workup pre-op. Remember, you did your CT scan before, di ba? Before therapy. Then while doing the therapy, you repeated your CT scan. And then how many weeks after, you tell the patient, okay, it's time to do surgery. What do you do before you do your surgery? Are you going to repeat your CT scan? Are you going to repeat your ECG or do a 2D echo for a 60-year-old patient? So those kinds of things that you need.
Okay, Doc. And for the guidelines, doc, for laparoscopic surgery? Which guidelines should we follow? Because there is not much information in NCCN about that one.
It's not in the NCCN. It's actually in SWARTS. If you look at your SWARTS, your basics in surgery, you have there your what you call your cardiopulmonary clearance. So that's basic. It's not specific to GIST. It's specific to all types of surgery. So before doing surgical procedures on elderly or high-risk individuals, you need to do your cardiopulmonary clearance. What is specific in for GIST and what is stated in NCCN is your metastatic workup that you should also do for this patient before going into surgery.
Okay, doc. Thank you.
Okay, anything else? Ayan na. So, ready na for tomorrow, di ba? Tomorrow?
Yes, Doc, tomorrow morning.
Sige. So, just summarize or wrap up your report. You can talk it amongst yourselves na lang. Just add some of the discussion. So, discussion, what you want to convey in the discussion is you want to defend, you want to tell the panel. Okay, so the panel that will be interviewing you tomorrow, you want to tell the panel na you did the right thing for this patient. And your discussion is where you will present the data. Okay, I did my, let's say, like, I want to tell you that my call to do preoperative neoadjuvant or preoperative immaterial in this patient was correct based on this data. And then present that in your discussion. The reason why we did the following surgery, okay, what specific surgery are you going to do for this patient? You have to be specific. What specific surgery based on your CT scan? What specific surgery are you going to do for this patient based on the CT scan and based on your endoscopy? So what specific surgery, and put it in the discussion that this type of surgery is recommended for GIST because the other types of surgery is not needed, like that. So that's how you present your, or that's how you go about with your case discussion.
Okay, doc.
Okay. Sige, if there are no more questions, that's it. That's it for the meeting na lang. Then good luck for tomorrow's case discussion.
Thank you so much,